I think it's time, I think. Don't you think
Perfect.
so?
Yeah,
Okay. Well,
sounds
let's
great.
start. Wonderful. No introduction needed, I think.
No, we've all gotten to know each other really well the past year. So if we don't know each other's name by now, we are in for some trouble. But last time, to let us kind of go where we were before, we said we wanted to do an atrial modeling paper. So I looked through the recent papers to look to see what's out there and something that's kind of clinically oriented as well. And I found this paper, and I'm not biased by picking one from Patrick Boyle, but I did find one that was in one of the more decent journals, and it seemed to be really kind of relevant to what we're doing with patient specific modeling. And anyone who doesn't know Pat was actually Ed's PhD student. I worked with Pat during his postdoc in Baltimore, so he's really in this kind of small community that does kind of all types of modeling. He's really kind of been around and seen the different groups. So from reading the paper, I do think he does a very thorough job. So this is a good example of looking at a modeling study, but while also keeping it simple and relevant. So with that said, basically, I know everyone here is probably familiar with computer modeling, but my only real backup slide is from myself. But the way it really works is this patient-specific modeling is that you go into the MRI and you can get an image, or also a CT, and you can get the geometry of your heart model. And we can build computer models of these hearts. So the real specific part is the geometry, but you can also get information on fibrosis, and with mapping, you can get some information about the um, electrophysiology. And ultimately, at the very end, hold on, let me reduce this, downsize this. There we go. Now I can see all my slides. And let me get my pointer. Cool. So really the idea is that we want to model the electrophysiology within the atrium as close to the patient as possible. And particularly, we want to study arrhythmias. And in this case, which we're talking about, is atrial fibrillation. And so what you're seeing here, and you'll see in some of the later maps, are these color maps, which really show you the membrane potential within the heart. And you can see that you can get different abnormal activities during AF, particularly rotors, macro tachycardias, and things that we'll discuss more later. But really, in a nutshell, this is why it's called patient-specific modeling, is that the patient gets a lot of data that we build models from. So the AF should be closer to what the patient is experiencing, which the idea is that it's not the same in every patient. So why do this? This paper is really geared towards ablation. So they want to use these models to help identify ablation targets, which then can help you test and optimize different ablation strategies. And particularly, as I just mentioned, really the specificity in this case so far really comes from the MRI. And if you do late GAD enhancement, you can get information as well as the fibrosis and the ablation scars. However, as this paper points out, that one of the problems is that we really don't match the EP different types of properties specific to the heart. So we know the geometry, we know some of the fibrosis, we know the distribution, but we don't have a lot of tailored EP to these different models. And so what they argue that this then limits the ability of this model to actually realistically simulate the AF, and therefore makes its use in these ablation studies not that great. So their hypothesis is, building on this premise, that conduction velocity is not equal in the left atrium of patients with persistent AF. So assuming this is true, they hypothesis that modulating conduction velocity in persistent AF models can improve the agreement of the simulations with the clinical observations. And as I mentioned before, this should help improve the predictability, the usefulness of this model with direct translation to the clinic. So in other words, it just means that modeling the geometry and fibrosis alone is not as good as modeling also the EP to help get these AFI simulations to match what we see in the directly in the patient. So the objectives, they wanted to determine how, if changing conduction velocity in the patient will impact the agreement of the arrhythmia seen in the model with that seen in the patient. And they do this before and after ablation. And then they also wanted to investigate the relationship of this with the characteristics of the patient as well as known risk factors. So the retrospective data they obtained from a single center is 37 patients. So they have 37 patients that have been diagnosed with persistent AF, and they have LGE MRI data before and after the ablation, which is really nice for modeling. And this is something we'll see later as a really powerful data set. And the patients didn't have any prior ablations, so there were no scars and things before that would complicate this before and after to try to make the patients as close as possible. And they had ECG monitoring to look at the arrhythmias that would happen after the ablation. So they did monitor these patients for up to 3, 6, and 12 months. And they've also did follow up at 2 years. So they had a lot of information to know if the patient were to go into an arrhythmias, which they called recurrence. And they classified them in 2 cases. They either had AF or atrial flutter. And you were non-recurrent if there was none of this activity of arrhythmias with up to 2 years after the ablation procedure. And as usual, we have a control group in most modeling studies, and they chose, and I don't know where the data specifically came from, it wasn't defined, but they had 4 patients of various age, BMI, and fibrosis percentages to try to compare with the results in these models with patients that did have AF. And so the patient data here is just, these things are always kind of detailed, but the things that struck out to me was that this patient group particularly, most had relatively high BMIs. They had increases of risk for AF due to fibrosis from the LGE alone. So all of them have fibrosis. And the other thing I found interesting is that the ablation is not a one-size-fits-all. They have many different ablation procedures, from cryo to radiofrequency to even one Mays Cox, which I don't know why that's even an ablation type, but there is many different approaches. So the strategy for the ablation is not the same. But the patient cohort, we can agree that before and after, they all had fibrosis and they were all relatively had risk factors for AF. So the methods, they have a very nice figure for their methods. And so it goes back to the process I talked before. They have to build the 3D left atrial models, and they did this using MRI. So they have the model, and using the late GAD data, they could use...
Sorry, Jason, can I ask a question about the table?
Yeah, sure.
Slide, yeah.
Let me go back.
Yeah, thanks. I noticed that the AF ablation type consists of pulmonary vein isolation in combination with substrate modification, SM, I suppose. Now, PVI alone is not directed at changing the substrate in the atrium and is not related to fibrosis probably, but to another mechanism, probably a focal origin in the PV region. So I wonder why they included those PVI only groups.
It's because I think every patient had, all of them had basically PVI. And I think they looked for different cases, as will become clear. They want ones that have reoccurrent and non-reoccurrent. So they didn't want necessarily a successful ablation either, from what I understand. The number of patients they want is the most as possible of different cases where it fails and also fails and doesn't have arrhythmias and does. So the PVI only, I imagine, would be a nice case to tell whether the ablation changed the arrhythmia type or not as well later, because they classify as tachycardia, around a non-conductive region versus rotors, which are not anchored to anywhere. So I imagine this case internally, maybe in the beginning, they thought that had a value, but it doesn't play out in the rest of the paper. They don't really focus on that.
Okay.
But I can imagine in the
But
very
I think
beginning, sorry.
PVI only is directed at the trigger of the arrhythmia, not so much to the substrate. That's the point I want to make.
Yeah, and you are correct. And I think their point of this paper is to show that the model will induce an arrhythmia in the cases when it should, and it will induce an arrhythmia when it doesn't.
Okay.
So it's not really trigger oriented because they pace from all over. At 15 different sites later. Yeah, but
PVI also slightly decreases the surface area.
Yeah.
And nothing has been shown superior to PVI alone, even though some of those cases must involve substrate.
Yeah, you can see that most of the PVI alone is on cryo, which is typical of the technique.
Yeah.
Jason, could you tell me what is the strength of the MRI? Is it a 1.5 Tesla, 3 Tesla?
They don't mention, but I'm sure it was a clinical MRI. From what I've seen, the resolutions aren't like very striking. So 1.5 Tesla would make sense from what they were doing.
All right, thanks.
Yeah.
I agree that these patients are quite chubby.
Yes.
All of them.
Yes, they're all in Seattle. I guess this center was. So they all come from the US. So this seems actually very typical.
I can't comment.
At least I can, but yeah. But yeah. And they're also around 60s, and being a little obese. This is very, very, very common. All right, so moving on. Let me get back my laser pointer. Cool. So back to the model construction. So, this is where the resolution, as I was showing, is not anything super striking. So I assume it's around a 1.5 Tesla. And they model the left atrium. So they get the geometry from the MRI, which you can see here. And then they have let me open this, will help too. These models are bilayers, so they have endo and epi layers. This is a lot of stuff that Ed's work was doing when I first got here. So they build a lot upon that work. So these models are kind of in the trend of what everyone's doing. They use AF parameters in the model. So the general EP is based on some old ionic models of the atrial cells, and they have AF. So that means the APD is relatively short and the shapes are triangular. And the fibrosis, as you can see from the image here, they have the typical thresholding approach, and they have before and after. So they know that even more highlighted areas, the more intensity, they have the scar information. So you can see in green the fibrosis, and then in red here is the scar. So they have both before and after. And what they do is they just reduce the conductivity in the elements of the mesh that has the fibrosis. We'll talk to a little bit more details of that, but this is pretty standard approach. And what they're doing is they don't really know for sure what the conduction velocity is in all these patients. They only have maybe a subset of 8 where they know this. So they determine a range. So they basically increase as well as decrease the conduction velocity. And in the model, they do that just by changing the conductivities. And this kind of goes back to what we said before. The PVIs are gone, but all of this is inducibility. So the triggers from the veins and everything are gone, but they pace from these 15 sites where triggers are supposed to come from, apparently based on literature searches that they've done. So they have 15 sites that they pace from, and they classify either it as inducible or non-inducible. And it's inducible if for 5 seconds the arrhythmia persists. And then they do a second classification that if you have an arrhythmia for 5 seconds, if it has 2 or more rotations around a non-conductive tissue area, they call it a rotor. And they call it macroscopic tachycardia, reentrant tachycardia, if you have an anchor site. So, for example, around the mitral valve or around one of the veins. And atrial flutter is basically the same as the macro reentrant tachycardia. It's just that it has a fast frequency. So they're really only classifying two different types of arrhythmias. And then the last part of the study is they say, okay, well, if we do this in the model, we have this big kind of parameter search that we've done, and we've done these different types of models for inducibility, and then they wanted to compare them with the patient data. So they knew the outcome of the arrhythmia after the ablation procedure, as well as they knew the behavior of the inducibility from the pre-ablation EP studies. So all they did was say that before, during the pre-ablation models, they just checked to see whether the model you could induce an arrhythmia or not, and how that agreed with the patient. And then they did that for 3 cases where post-ablation in certain patients where AF was the arrhythmia that was considered to reoccur after the ablation. Again, was it a rotor or not a rotor? Then for the cases where they had the atrial flutter, was it a tachycardia or not? Did it agree? And in some cases where there was no reoccurrence at all, could they also reproduce that? And so with that said, going back to the conduction, just to give a little more details, this was from the supplement. You can see that from the region here of the LA, where in green you have the fibrosis and in blue here is the non-fibrotic tissue. And you can see that when they change the conduction velocity across their range, you can see that you have less crowding of the isolines as you increase the CV parameters, which all they're doing is changing the properties of the tissue based on this scaling factor. So they make the conduction along these regions faster. So you'll see 0.85 8.5 meters per second as relatively some of the faster ones, and some of the slower ones are around 0.572 meters per second. So that's what's considered slow. But this is pretty typical, again, of what people do in different types of modeling studies. And they do in their methods as well. There are patients that do have some mapping. So, okay, are these CVs that they are putting into the model, do they actually match what the patients are? So to verify this, there is an approach they use that they measured conduction velocity between 2 points in the LA from EP mapping studies, and they take the mean, and then they would compare that to the conduction values that they had assumed in their model. So getting into the results, before I get there, is there any questions on the methodology to this point? Anything that strikes you as being odd or not really familiar with? Okay, if not, then I'll move on to the results. And so what they did in the upper left here, for all of these simulations, pre and post ablation, they just are plotting the number of simulations which they consider inducible. So the arrhythmia lasted for 5 seconds, and then they classified it in green as a rotor, or in kind of this purple as a tachycardia. And the general observation is that as you reduce CV, you have more simulations that have inducibility of rotors as well as the tachycardia. And then the second thing, they then did it pre and post ablation, and they noticed that before the ablation procedure, amongst those inducible arrhythmias, most were rotors, but after the ablation, most were tachycardia. And in the panel C down here, they're mentioning that in general, with the slower CV, the mean kind of inducible simulations per the model specifically also goes up as the slower the CV is. But I also noticed, they didn't really highlight this, but for some reason post-ablation as well, there seems to be overall more inducibility of an arrhythmia. And again, this is just in the specific models to show you, to show that there were less rotors during post-ablation and more macro reentrant tachycardias. So they see 2 different types of arrhythmias, but overall, as conduction velocity gets slower, they seem to see more arrhythmias in both cases.
I have
Yep.
some
Sure.
comment on the difference between panel A and B is, I think B is normalized and ablation should correspond to A. Wouldn't you expect that? Or
sorry, can you repeat the second part? I missed it.
I think the pre-ablation part of panel B should be more or less the same as the panel A. Is that correct?
This is slightly, yes. So I put up here, actually, I added here per each of the conduction velocities that they measured, there was 1,110 simulations total.
Yeah.
So that helps me understand that, and I could do the percentage from that, but I don't know the pre and post. And like what you're saying is, I actually was doing a double take when I was also kind of looking at this. I don't necessarily think that panel A is really that relevant without knowing the total number of simulations ran.
Yes.
Yes.
Well, they're 1,100 per theta.
Yeah. So for each column here is 1,100
Yeah.
simulations. So.
You see that about 30% is in the OA 0.8 group is inducible.
Exactly.
And then it's normalized in panel B to 100% for each. But then I think if you look at the 1.2 in panel A, there's a majority is dark blue and a minority is green, and it's the other way around in panel B. So is there a reversal of coding? I think so.
I would presume so, yeah. I mean, there should be.
Yeah. So blue and green should be inverted.
Yes. Should be.
I think so. Yeah. Okay.
Yeah. Yeah. And it's actually quite interesting when I was talking to Pat about the paper. This is just the students you're working with. So the study was done by a clinician. So a lot of the interpretation should hopefully, be a little more clinically relevant. But it's just interesting to see that the person who did this paper was not actually a computer modeler at all. So I noticed some things in the paper that are missing, some details, even the mesh size of the simulations, of what the MRI was being used and all these things. So there's a lot of little details that are even missing in the supplement. So this is why this paper is also very interesting. So bring these things up whenever they come about, if anyone sees some more. And so here's the results in the control patients. So they had the different control patients. They did the same protocols, the same stimulation sites, the same conduction velocities, but there wasn't really much fibrosis in them. But they did have a range. They did have some patients that did have more fibrosis than others, so that kind of compared to the group that we were looking at. But given these patients, they were not able to induce any sustained arrhythmias. And so this was just a quick figure to say that they weren't able to generate any arrhythmias in these. So the models they're seeing are from the parameters, the patient-specific parameters, as well as the CV modulation. So the combination of those two is generating arrhythmias that are closer to the patient. And so the next figure they're showing is giving 4 different examples of what the model can do after the modulation of the conduction velocity. So here's a case where they have non-inducible post-ablation, but the AF was recurrent. So they only got an arrhythmia, in this case a rotor, because it's not around anywhere that is non-conductive. They got the rotor only by reducing the conduction velocity. So if you had a model with default parameters, you wouldn't see anything. But if you would reduce the conduction velocity for this patient, then you would get a better match to what was happening in the patient after the ablation. And again here, Here's an example of the macro reentrant tachycardia. Here's one around the mitral valve. And again, they only got this pre-ablation. This is what the patient had before. And they only got this when they, again, reduced the CV in the model. And here's another example of non-inducible pre-ablation, where the modulation, when they increase the conduction velocity, so they had it both ways, when they decreased as well as increased, you get different types of behaviors closer to the patient. And the last one is just another example of a rotor, whereas a non-inducible post-ablation AF reoccurrent model, so very similar to this one, but in this case they had to increase it. So it seems that the modulation is important. Now the question is do you decrease or increase, or is there a one-size-fits-all to even this approach without EP mapping? So here, I'm just going to move this. There we go. Sorry about that. I had to move these little, get my pointer back where I can see it. There we go. So in the upper left-hand panel, now they're just really looking at the model agreement. So they want to say that amongst all those simulations that we saw, do they agree with what the patient was diagnosed with or presenting within the clinic? And overall, it seemed to have an increased agreement with modulation. So modulation's on the right, the baseline, the default parameters are on the left. Pre-ablation, there was an increase. There seems to be a significant increase in the ability of the models to agree with what the patient was having with the modulation. And post-ablation as well, but particularly for the AF reoccurrent, but not for the atrial flutter or when they had non-recurrent. There wasn't much of a difference with and without the CV modulation. And overall, there seems to be a more agreement, as I said before, like is it, more cases where you increase or decrease? It seems like the agreement goes up in general as when you decrease the conduction velocity from right to left here. So you see more and more number of simulations that agree with what is observed in the patient. And this figure just again shows that there's more agreement with slower CV within the individual models rather than looking at the lump data, taking one individual model, but it doesn't seem to be as significant as when they show it as a lumped data. And again, the interesting part for me was that this CV modulation was helpful for those two categories, but it really didn't do anything when it was atrial flutter, which again is nothing but their tachycardial classification of an arrhythmia, and the non-recurrent. So when there wasn't a arrhythmia after the ablation, it didn't really matter what you put into the model for the CV parameter. And so then looking at this now, the next thing they wanted to say is, okay, well, does this modulation in these models and the agreements, are there any dependencies on the different characteristics of the patient as well as the risk factors? So in this figure, you're looking all at the pre-ablation data. And overall, when they looked at age and gender and certain aspects like that, they did not find any difference. However, they did see that for the patients that had higher BMI, which they chose below and above 32, I don't know why, because below 30 still has higher BMI. How they chose these thresholds, I don't really know, but they didn't explain. But the thresholding, it seems to be that when you have a higher BMI in the patient classification than others, the agreement in the model is better. So means that we probably would have to, if you have a patient come to the actual people that have higher BMIs, they might benefit more from this CV modulation from a simulation standpoint. And the same thing for fibrosis. They saw a similar trend, as well as with sleep apnea and also hypertension. However, when they looked at different drugs that they were taking, particularly a potassium channel blocker, which is amodiarone, they didn't see really any statistical difference. They saw changes, but there wasn't anything that really said this was something that across the board would change. And as well as for beta blockers. And overall, it really, the 4 top panels is just saying that these patients that have these high risks, there's something going on that's probably affecting the conduction velocity, and therefore they would benefit from this modulation. And then the last part was they wanted to verify that the conduction velocities were within the range that the patients would have. So in 8 of the patients of the 37, they have conduction velocities that they measured using that systematic approach where they measured at several different points within the left atrium. And they particularly found a pretty wide range, but they found conduction velocities in the fibrotic areas as low as 0.46 and as well as in the myocardium as high as 1.45 meters per second. And the modeling that they used, the ranges were anywhere between 0.5 and 0.85. So they're within kind of this physiological range. They're not specific, they're not patient specific, but they're at least within the range of the conduction velocities that were being observed within these patients. So to summarize the study, this figure kind of does it all. They had patients from a single cohort where they had data about the arrhythmia before and after ablation. So they had MRI as well during these times, so they could calculate the fibrosis and include it within the models. And within these patients, again, they took the clinical phenotypes. So pre-ablation, they identified them either as rotors, if you could induce that, or a tachycardia. And then for after ablation, you either had a classification of recurrent AF, and that was either a rotor, or you could have atrial flutter that reoccurred, and this would be classified as a tachycardia, or you have no arrhythmia at all. And so giving those 4 kind of phenotypes, those 3 different types of phenotypes for afterwards, you can see that here is the with and without the conduction velocity modulation. So they changed it across their ranges. So blue is good and red is bad. And you see that pretty much for the AF recurrent and pre-ablation persistent AF, the CV modulation drastically improved the ability of the model to predict and reproduce the arrhythmias within these hearts. Whereas for the atrial flutter and the non-recurrent, there wasn't much of an improvement at all, or change even. So what they conclude is that CV modulation improves the kind of model/clinical agreement for AF patients at pre-ablation and post-ablation with recurrent AF. At slower conduction velocities, pre-ablation models presented more rotors, where post-ablation models presented more macro reentrant tachycardias. And models agreed most for patients with high BMI, fibrosis, obstructive sleep apnea, hypertension, but not for gender, age, and anti-arrhythmic drugs. So with all of this study, it seemed pretty straightforward. Their real focus was on conduction velocity and do we need to change that in patient-specific models? I feel that yes, it would make sense. It's not really anything revolutionary in that sense, because we all know that wavelength depends on conduction velocity. So the type of arrhythmia you get, also given with respect to the PDI shrinking the area, it would make sense even towards what type of arrhythmia you get is what you set as your conduction velocity. And I do believe that not all conduction velocity is the same in each of these patients. And why they see more tachycardias later, it goes down to the surface area problem, the wavelength with respect to that. So we can probably really dig deeper and figure out why these types of arrhythmias are happening if we wanted to with different types of models. But they did not go any further than that. But I still have many questions. Will CD modulation actually improve ablation outcome predictions? I don't think we know enough about how the ablation actually works yet to find exact targets. So even though we reproduce the arrhythmia better, I still don't know if it's going to improve how the model predicts the arrhythmia. I mean, the actual therapy. I do predict, that they use different ablation therapies and things, but I'm not so sure that it still will drastically improve that. It'll just be a closer representation of what is being mimicked in the patient. One big thing for me is that they do omit the right atrium, and there's triggers from there, as well as its role in maintenance. I don't really know, by removing the right atrium, does this actually impact the maintenance aspect of all these? Because they're really looking at these recurrent arrhythmias, changing the CV. Maybe, maybe not. It's just something I don't know. It's we do this often to increase speed, as well as the eliminating the amount of data we have to match in both atrium. But I don't know any good studies. Maybe Ed or someone else knows, but have we, really ruled out the impact of the right atrium and maintenance of left atrium arrhythmias? And then the last point, which then we can discuss all these in a debate, is really kind of their ideas is that, well, you can look at the growth factor TGF beta 1 and say, okay, well, it's increased or decreased in patients, and that should be an indication of CV modulation, right? So you might need it or not. However, it also influences sodium channels as well as potassium channels. So I don't think it's so straightforward. There's a missing piece for me. There has to be different approaches to this study by, rather than just looking at changes of conductivity, so you have to change the sodium channel. You would also, I would suggest changing the APD from the potassium channels a little bit, but that could be done as a second study. But what I would like to see in this study is modulation via changes in the sodium channel as well, rather than just that, to see if there is differences. And that would have been interesting to me. So it's a very good study. It's I know the courses we take with the master's students was there's a course of how to review a paper by Stan Natel is, do they state a clear hypothesis and do they actually provide data for that specific hypothesis and not something else? I think they did that. But is it a perfect study? Absolutely not. I think there's a lot that could still be done. And that's kind of where I will leave it for now. And I'm sure people have a lot to chime in. So I think now is the time for that.
Okay, very good. Well presented, Jason. Thank you very much.
Thank you.
I was triggered by your by the comparison of the conduction velocities in these patients and that they are so different. We did a study in atrial tissue, human atrial tissue, with a lot of fibrosis in it, and measured conduction velocity by optical mapping. And it was very complex because if there was long fibrous strands, then the conduction velocity in the myocardium between these strands was actually higher than normal. Whereas when there was more diffuse fibrosis, there was a delay of activation because of the tortuosity of the pathway. So it's very complex, I think. But yeah, of course, the conduction velocity is modeled to be decreased because of the not because of the sodium channel characteristics, but because of the structure. So it's just like the myocardial infarction, that there's tortuosity, so conduction delay rather than slowing of conduction. Or am I wrong?
No, I think without changes in that, it's really just an overall delay. Yes, I mean, it could be pathways, it could be, the type of fibrosis. I mean, this is the thing: is conduction velocity for me is a very general term. A lot can go on between 2 points within a model. Even within the patient's coherent maps are supposed to help with this, right? To try to determine pathways of conduction velocity in this, but I still think it's a lot goes on. Models, we can show you exactly why it's happening. Like we'll say, oh, we can look at two very small points and say that the change of conduction velocity is specifically due to the distribution of the fibrosis, right? So it's actually slowing it down, maybe making the propagation more isotropic or something. But at the clinical level, when you're looking at it, it either has to be, going around something or blocking something, or there's something actually slowing down the action potential. I think it's hard to tell from that aspect. And this is why I think from the modeling side, you need to cover all the grounds and do everything, which is kind of similar to studies of what Caroline and Ed did. And before we're even looking at fibrosis, is you can model fibrosis differently by changing conductivities or changing ionic channel properties or changing the distribution, and you get completely different results. And particularly with arrhythmias. So this is something as well, by assuming that the fibrosis modeling you're doing is actually matching this, it's too singular, right? This problem is probably much more complicated. You'd have to have many different types of fibrosis and many different things, and yeah, and even these
How did you
patients.
do that? I remember the percolation paper. Were you involved in that, or Ed?
That was Ed's. Yeah, he was the percolating master. Yeah.
Yeah, it was a wonderful paper. Did you slow conduction there?
No, not at all. If you have enough disruptions to the connections, it just I left sodium the same. You just get slower velocity.
Yeah. Right. Okay.
Yeah. Because even back on our paper with acetylcholine, it was very tough when you were measuring conduction velocity between two points. You don't know if it slows and then speeds, or speeds then slows, or between that area. And it could be a combination of many things. It's it's really tricky. But my question to you then is: do you believe that these coherent maps really give you good estimates of conduction velocity from the clinical side?
I'm not sure. I wrote a paper about how to measure conduction velocity, and the bottom line was that you shouldn't use these vector maps because they are very inaccurate, probably. But that you should use central pacing in a grid of electrodes. That's the best way to measure conduction velocity. But of course, that's not always possible, certainly not in clinical cardiology. So there, essentially what they say is conduction slowing is often conduction delay rather than something to do with the upstroke of the action potential. So, but the answer to your question is I don't know.
Well, in clinic, nobody talks about conduction velocity for this reason, because they know what they're measuring. It's just an annotation of the activation. So
yeah, exactly.
In our animal models, typically the conduction activation between regions slows down, whether it's due to fibrosis or inflammatory superposition. This we don't know. There's fibrotic substrate for sure. It's diffuse fibrosis, so it can be due to tortuosity. Indeed, I never saw in an animal an increase in point by point activation time.
Okay,
it's going to be interesting. It's going to be interesting to see in redo ablation patients, where these patients have scars that for sure create blocks, unless they don't find that there is like PV reconnection or something like this.
Yeah.
I was wondering if this is a good case for ECGI, because you mentioned that. I mean, does this model make sense if we don't have EP data? I'm just wondering. I'm not an expert of ECGI, or by all means. What do you think?
I mean, for atrium, I don't know how well ECGI works. All the stuff I see is both. I mean, I myself don't know how accurate you can get with conduction, but it would make sense because you only have a surface. So if you could get the whole surface of the atrium, then it would work well. So for ventricles, I don't believe so. But for atrium, if you can get a good idea, I mean, that would definitely be a way to look at general ranges of parameters, right? And I think what the model does do well, oftentimes we don't have data, or we don't know data, and we don't know these are retrospective studies, so we can't go collect the data. which they did well here, is they provided a range, right? So they now have identified the range of things which we should look for. And if ECGI can look at slow conduction really well, then it would be a good tool to use, right? But let's say ECGI doesn't do well around looking at slow conduction based on structural things, then no, it won't work. But I mean, I think this is what the modeling does well, is it determines what we should look for, and now where can we get that EP data? And yes, we should look at all avenues to do that. And I think we do. I mean, kind of the gold standards for us is, catheter mapping is great, but ECGI would be something you could do many times during these follow-ups, but you already have catheters in there. So, I mean, they could just measure places and specific locations if they really wanted during the inducibility follow-ups and things. So,
No, I mean, I don't think that ECGI will ever have the resolution to
yeah.
distinguish any possible arrhythmia, unless there is not one. This is something that I discussed with Amael, for example, here. Unless there is not a single or a multiple focus, then you know where it is, and then and it's kind of macroscopic. Then you can see where it comes from. And based on your imaging, you might predict how it will evolve. And I don't think that any kind of arrhythmia is describable by that technique. Another thing is like in terms of sinus, because like when I understand that here, this is a global conduction velocity that is changed. So it's not like, for example, next to the PVs is one value, on the appendage is another value, and so on, so on, so on. So maybe in this kind of macroscopic sense, like for example, from left to right of the chamber, from posterior to anterior, I don't know, maybe it makes sense, but again, I'm not an expert. For sure, the right atrium is at least in our test is implicated in the start of the arrhythmia. I don't know the maintenance, but the start is there.
Yeah. Well, one of the big gradients that we model is between the veins and the actual myocardial body itself, but with the PVI, it's gone, right? So they take a lot of these gradients away as well with that. So for the post-ablation, it will work, but for the pre-ablation, I do agree with you.
Yes.
There are these gradients probably play a big role, and you saw that the agreement, the number of arrhythmias and everything was much higher afterwards as well. So I believe that, this is one of the roles why it wasn't so great in the beginning.
I believe that even post-ablation in the Marshall bundle, there will be these gradients still preserved, at least as an anatomical reference, because we saw it even in the animals, that they have this preferential acceleration where when we impose an extra stimulus, we see that the conduction changes. From posterior to anterior, it passes through the. I mean, they don't have a Marshall ligament, they don't have a Marshall vein, but it would be in the humans. It would be there.
Okay.
Yeah.
Vladimir has a question.
Yes, he does, and I have to turn off my mic because he's in the same room here. So.
Oh, okay.
All right, mic is going off now.
Great. Thanks, Jason, for the very interesting presentation of an interesting paper. So I have some remarks on what you presented and what's shown in the paper. So looking at the conduction velocities, indeed the range here is pretty high. And I just wanted to mention that when I was in Maastricht and we were doing experiments in goats, we basically set the limits to conduction velocity values that we trust. And we basically said we trust values that are above 0.2 and below 1.2 meters per second. So when I see here that there are 2 patients out of these 8 with the conduction velocities above 1.2 meters per second, it's something that I wouldn't, for example, trust that much those values, just based on my experience. Then I had a question I forgot to ask when you were describing methods. When they were taking the post ablation MRI Like, what was the time window? Like, how long after the ablation was this taken?
Unmute here. Regarding your first comment, yeah, I'm 100% in agreement with you. 145 seems a little weird for atrial myocardium. Purkinje maybe yes, but not that. And luckily they chose values that are well below the kind of means that they're getting in these patients. So that's a very good point, and I agree with you. Regarding your second one, your question, in terms of the methods, and let me go back here. The day I remember in the paper is that they have a blanking period of about 90 days. I think it's around the average time between the ablation and the end was 100 days roughly. And I think all of the follow-up predominantly was, up to, I think, 150 days or whatever. I mean, overall, like the range, kind of like the last ones were around then. So it was quite a difference when they started really analyzing the arrhythmias, and the reoccurrence was, I don't know if that's difference, whether you do it at 90 days or 150 days, is there a big difference, in terms of scar healing and things like that? I think the objective was to get far enough away that the scar has kind of done its thing in the whole healing process and then did the study. But I really don't know, why they chose those time points and if they would impact the study.
Okay, thanks. And then my third remark is about this topic about the absence of right atrium, because indeed, the moment we are using just left atrial models and like the simulations, everything's basically this is left atrial study, right? Then the assumption is not only scientific but also clinical assumption is that left atrium is where all the arrhythmogenic substrate is and where all possible triggers are, right? Because that's basically the assumption you are making if you don't include the right atrium in the treatment or in the modeling.
Yeah.
Right. So then when the simulation phenotype doesn't really match the clinical phenotype, to what degree is this due to some parameter like I can tune? And to what degree is due to the fact that I'm lacking part of the substrate or some triggers which are in the contralateral atrium?
So this is what I don't know. This is something I kind of alluded to would be an interesting study. I don't know if people have. I mean, Ed may have known some studies they were, but the only atrial paper I did with ablation, I kept the right atrium in. I only showed the left atrium, but the whole modeling study was with the two together because I realized that when I was trying to match some clinical arrhythmia data with Michel, where he had some data on inducibility, I needed the right atrium just for the maintenance of the arrhythmia. I have no idea why. I didn't look into it any further than that. So I think if there's a study to be done from a modeling side is what is the importance of the right atrium for arrhythmia maintenance and triggers, substrate, all these things. And is there like some kind of, who has done? Caroline's done it recently? Yeah. Because then it's like, I haven't read this study, but is there a parameter, that you can tweak and say that, 10% of these cases are probably due to, or just 10% uncertainty or something in your things without left atrium? And when was this study? When was her paper about this?
Good question. I think I'm included on the study too. So basically, the gist of it is, if you want to stop re-entry, you should ablate the interatrial connections. So yeah, the right atria, I mean, it's there. It's if things get blocked in the left, and then there's activity going on in the right, and they come back to the left side and restart everything again.
Yeah. But also triggers are noticed.
They could be in the right as
Yeah, exactly. The caval veins. Yeah.
Not the inferior though.
No, it's funny, huh?
Yeah.
The atria are weird.
I always wonder whether the inclusion of an AV node would help as a structure that truly has slow conduction in it. Have you
I have
ever
some
tried?
thoughts now that there actually is not slow conduction in the AV node. There's not a slow and there's a slow and path pathway, but it's not functional. It's
No, but the calcium, there are calcium-driven action potentials, and the conduction velocity is about 10 to 20 centimeter per second, I think. It's not sodium current dependent. So there is slow conduction in that tissue. So I wonder what happens if you add a little bean of slow conduction in your model, whether that would help.
Well, I don't know. I mean, it's just the lazy side of modeling. Just throw it in there and find out, right? It's yeah, we can answer infinite number of questions. Just keep putting things in.
Yeah, sorry.
The point is, what do you need?
Yeah.
What kind of data you need? Like, what the quality level of the data? Whether, for example, one system is better than the other. It's if the Carto system is better than the Rhythmia system, it's better than the Insight. If the algorithm should be completely mistrusted and everything should be recalculated by you, the imaging should be CT, photon counting CT, should be MRI, should be 3 Tesla MRI. I think this defines a lot of your problem.
Yep. I mean, to be honest with you, a lot of this comes from experience as well. When you start working with the clinical data over time, you learn some things that I don't think we always discuss or publish. You know, it's like which data system gives you the best thing of this and that, and and where you get it, and to get your model to work sometimes is yeah, that you are 100% correct. There is some kind of trade secrets in that aspect and knowledge and things you have to put into it. So it isn't just as easy as adding things. You are correct.
Yeah. I mean,
But,
I can tell you from experience, like if you're looking at automatic annotation and resolution, the Rhythmia system is the best.
Yeah.
If you're looking at, I don't know, versatility in terms of algorithms or annotations, probably the Carto system is well, the Insight also is quite okay. Like, do you like if you trust raw data, probably right now what we're using is mostly the Rhythmia because of the high resolution and the fact that the annotation is I have to clean, for example, 10% of the map. With the Carto, I risk to clean like 30%, 40% of the map sometimes.
okay.
And for the MRI, I mean for the imaging, it makes a lot of difference. Like I don't know, well, not well for the atrium. Fortunately, it's very limited.
Yeah.
Not the 3 Tesla, but one that we have is fairly limited.
Okay.
No, there is no doubt about in my mind that the EP parameters for each patient should be fine-tuned a little further than just out-of-the-box things. And what that will open is the Pandora's box of which systems to use and how to use them and do it properly. It's good to know this because
no, with at least when I am concerned, you can use whatever you want.
Okay, I think we're approaching
Oh yeah, but a long discussion. Very nice.
Yes. So I've got one more minute. So I guess, does everyone agree that conduction velocity is important in patient-specific models for AF?
Yeah, but I wasn't a big fan of this paper.
Either.
All they proved was that if you decrease conduction velocity, you get more arrhythmias.
More re-entry. That's obvious, isn't it?
That's
obvious. And unfortunately, the paper couldn't tell us which way to move the conduction velocity a priori. So it's just a model sensitivity stuff. I mean, it's just he doesn't have the data there to prove it to actually do anything practical.
Yeah, it was very observational. I was like, here's a bunch of stuff. We did a bunch of things, and it matches.
We should improve how we measure conduction velocity. That's my take.
Well, Ed, don't you have a paper on conduction velocity coming out?
It should be coming out. Well, it should be submitted soon, hopefully.
All right, so we will send that to you, Guido. This will be
perfect. Thanks. Yeah. I'll look up Ruben's paper as well on the best method to measure conduction velocity.
Yeah,
See if we can tweak something.
good. Okay, I think we have to stop now.
Yeah.
Thank you very
Okay.
much, Jason.
Yeah.
Guido and I will come up with a proposal for next month, I think.
Yes.
Perfect.
Okay.
Thanks.
Thanks,
Thank
everyone.
you very much.
All right.
Thank you.
Yeah.
Bye.
Bye, everyone.
Bye.
Bye.